Welcome to another Wednesday, another webinar. It's 6:30 Eastern Time Wednesday, and we have our Wednesday webinars, right? It is the last one from our module, from removable module series. We had 1, 2, 3, 4, 5, 6 modules, and I am kind of happy we are the 6th module because we did it every week, right? It was kind of, man, we have to put it together. We have to be disciplined and be on air at Wednesday 6:30. But on the other side, it was so much fun. It's still fun. And we're decided in the future, we're going to do that more often. The Wednesday webinars is a really cool kind of hang on to join us and to then afterwards posting on YouTube. So everybody who cannot join us on Wednesday night after work, I know it's late and everybody's tired, can actually then watch the recording and still chat with us, still watch recording, message us with questions, etc., etc. So I'm super happy you have you guys in tonight again after work on Wednesday night. So today we're talking about attachment bar solutions. That's like, I would say, after last time when we talked about telescopes, one of my favorites because it's more complex. And it's definitely, sometimes it's the bailout case. That's what I like, or the bailout restoration, right? So I have Veronica with me today again, like every Wednesday, our Wednesday webinars, right? We do it together, Veronica and me, and it's gonna be fun. So today, and this is our last one, right? Attachment bar solution. So that was the whole series. We will show this schedule at the end again. By the way, if you want to have your CE credit, you have to wait all the way to the end. There will be a barcode or a QR code to actually take a screenshot or a photo or save it, that you can get your CE credit from Dental CE Solutions. What I want to say, thank you for your support for the whole module, for the whole series. Without you guys, we would not be able to have done that, right? It's really great. Thank you so much for supporting us here. By the way, conflict of interest, there's no financial interest in these webinars, so we don't get any money for. There's no sponsorship behind. Also, family members, there's nothing what's gonna support us here financially for these webinars. It's purely educational. That's our passion. That's what we like to do. We like to share our knowledge, our experience, basically, right? So a little bit about myself. Whoever is the first time with us or maybe watch the series right now the first time, my name is Alexander Wünsche. I am the co-owner and vice president of Zahntechnique. We are a high-end boutique dental laboratory in Miami, concentrating on really like more full arch, full mouth rehabilitations on aesthetic dentistry. We're full service, so we do everything from a flipper or a little flexible nest bit up to really full mouth rehabilitations. But our real expertise is actually in these complex cases and in aesthetic dentistry. We're on the forefront of digital dentistry, so we're always trying the latest and greatest in the industry. We're consulting many big industry partners on the implant side, on the material side as well. So we're testing a lot here in the lab as well. So that allows us actually to really know what's going on and share this with our audience. So that's really cool. It's especially a lot of fun, right? So, but nevertheless, I would like to introduce Veronica. She is with me tonight, like all the other Wednesdays as well. And Veronica is an amazing add-on to our laboratory and also for me here to educate. Veronica, she joined us in May this year, came all the way down from Portland in Maine, and is an amazing add-on support from my side here, especially on the removable side, where she's our removable department manager now. So Veronica, introduce yourself.
Good evening, and thank you, Alex, for the introduction. So I am originally from the Czech Republic, from Prague. I went to dental tech school there for 4 years before I moved to the United States, and I went straight to Maine. I was running a small dental lab in Portland for a few years, and then when my daughter grew up, I decided to join Zahntechnique, and it was time for a change. So I'm happy to be here in Miami with these guys, and yeah.
Awesome. Yeah, well, we're happy to have you. It's gonna be a cool ride over the next decades or so, right? Mm-hmm. So yes. It's gonna be a fun here in the lab. So yeah, I mean, this is something we did over the last modules, mm-hmm. and yeah, why not introducing it, right?
A little bit of a recap of the previous modules. So we started with the impression and the importance of the impression being great foundation for successful restoration. Then we also talked about VDO and establishing VDO and all the anatomical landmarks. In the next module, we were talking about face shape and tooth shape in coordination. We also talked about importance of the trine as well as the curve of Wilson, curve of Spee. And then in the following module, we talked about digital dentures and digital equipment needed for fabricating of digital dentures and some materials for printing and milling. Then we talked about attachments and different attachment systems. And Alex's favorite telescopes and their fabrication.
Yeah, so welcome to reality for today, right? That shouldn't shock you what you see right now, but that's basically sometimes we have to create space, right? We have to create space to actually put that patient back into quality of life, put that patient back into some restorative, not nightmare, some restorative actually good stuff, so that a patient can smile, laugh, and eat, and all these things. So sometimes you have to create space. Sometimes we can't create space, right? And that's like today a little bit about these challenges, right? So today we want to show you challenges in restorative implant full arch dentistry and solutions. We want to show you today, I want to introduce you for a specific attachment bar solution what we really love here at Zahntechnique, because it really works for us over decades now. It's nothing new actually, it's just like really improved over the years. And we also want to talk about the space requirement for full arch dentistry. We're going over the clinical steps in a little bit, right? So what you have to do chairside to actually achieve a successful full arch case with these attachments. And then also we discuss the materials available for that. That's very important. We also will cross a little bit about the analog versus digital. We talked about digital over the last modules already. So whatever you learned, whatever you took away from the last modules, you can reapply to these other later and more higher end modules as well. So don't forget to also watch the previous recordings from our other modules in YouTube. By the way, the last one from last week, the telescope one, is now online. So you can also watch that or rewatch it if you missed something or forgot something. So here we see the typical or the different types of overdentures. Basically, we talked about two supported in the last modules, implant supported in the last modules, basically. So about the telescopes, of course, we talked about different attachments already. But today we want to concentrate on the plunger attachment.
So here you have a really nice case, or seemingly really nice case, aesthetically very pleasing, aesthetically very right on, midline, smile line, tooth shade and shape, very, very nice. However, when the patient smiles big, we have a problem. Now you can all see the transition line between the gingiva and the ending of the acrylic on the bar.
Yeah, this actually happens quite often, right? So we see this sometimes if there is like poor planning or poor communication basically between the surgical clinician, the GP or the restorative clinician and the laboratory. There's poor communication. We're sometimes ending up with these results. They're really not very, well, it's another bad day in dentistry basically, right? So another thing is this, what we see often on our bench is situations like this. I mean, I don't know if there's any more space to put any more implants in some of the distances of the implants and then some gaps here. That is crazy, right? So these things are obviously not very pleasant to see, but believe me, we see these cases and we have these cases, and these are the cases where I go home like this at the end of the day. And so why are we doing this? Why do we have to really do it? But in reality, there are solutions for that, right? There are solutions, and that's kind of what's the general full arch challenge, right? That's our challenge, to find the solutions. I'm a fan of always giving multiple solutions, right? I'm not a fan of, oh, hey, we have a problem, that's your solution. That solution doesn't fit you or your patient, right? So we have to find multiple solutions. Like the telescope is a solution, what we discussed last time. But if I just talk telescopes, I'm not very valuable, right? So I have to be valuable to give different solutions. So what's the general challenge basically is in implant dentistry, especially full arch dentistry, is lip support, right? Or with the other challenges like the ridge position, right? The visible ridge, in general, ridge position, ridge shape, right? That can be really a challenge, especially for fixed restorations we maybe are often target. Another challenge in our full arch dentistry is the high smile line, right? That's like really like when we have the gummy high smile line and the patient shows literally everything. It smiles and it looks like the patient just folds the lip over the forehead. And that's like the situation where we all say, oh my God, please not. But that's happening and we have these patients. So we have to have solutions for these cases, right? Besides these examples, maintenance can be a challenge for some patients because there's a reason why these patients don't have teeth anymore and need a full arch restoration, besides maybe a sickness, disease, or accidents, right? But if it's just because of hygiene, maintenance can be a big problem. Retrievability can be a problem, right? Patients getting older and at some point, maybe they're ending up in the nursing home and they have to actually get help to clean their teeth. That can be a problem. So if the restoration is easy to retrieve out of the mouth, it's easy to have then our last point here, the hygiene, to have it hygienic and be able to clean everything nicely. That's important, right? So look at this patient, for example, here. That's a try-in of an MK1 case on the maxilla and the hybrid on the lower, on the mandible. And it's just perfect, right? It's aesthetically nice. Yes, there's a slight disbalance in her lip in terms of a slight cant, but the restoration is just beautiful. Enough lip support. That's what we would like to see for happy patients.
Okay, so if we have a problem, how can we think about a solution? So last week we talked about telescopic restoration, and today we're going to compare that with our MK1 bar.
Yeah, that's like what I just mentioned, right? I said, we don't want to just give you one solution. Now there have to be multiples, right? There have to be multiples because it has to fit any pocket and any kind of preference of either our client or the patient.
So why would you not use telescopes more than MK1 bar?
That's an awesome question, right? And we didn't train that question. It's just a good discussion here. So why? Very easy. A telescope restoration is one of my favorites, but it's very simple, these cases. But they don't have a locking mechanism, right? The MK1, what we see on the right side, that bar, you see the little holes in the bar on the side. There is literally a plunger locks into that hole. That restoration is like rock solid in the mouth. And some patients prefer that. Some doctors prefer that as well because they don't trust the situation. Oh, something is just like an adhesion fit on the telescopes and they don't trust, I'm chewing a chewing gum and it pulled it out, right, or candy. So they don't trust the process or they don't trust the situation. So they're with an MK1 with an attachment bar really well served because it's rock solid in the mouth. Nothing is moving, especially at night, right? So because all these restorations are not like a denture on the nightstand in your glass overnight. No, these restorations are the patient's teeth. We would like to see that 24/7 in the mouth. Just taken out for the typical hygiene in the morning and at night, brushing the teeth, taken out, clean everything, put it back in and sleep with it, right? That's the important thing. Even in this case, usually we apply a night guard to it. We suggest a night guard, just like to have it at night at least really covered and nothing happens. And even if you're bruxing or clinching or so, it's just covered, it's safe.
Okay, so then you can see here the double structure basically. On the left, we have the titanium bar that is melt with the plungers. And then on the right side, you can see the secondary frame that is actually melt or printed. And here in this case, it's printed.
So metal printing, right?
Yes.
That's a very interesting process actually. And there's a little history to it because we started metal printing these secondary frames like, I would say maybe 8 years ago or so in SLM, with selective laser melting. I have a video later on to show that came out. We tried it out. We designed these overstructures, these frames, and the fit was just amazing. And so I just liked the process and we played with different methods. But in the end, and we may be repeating this later on, I wouldn't say, if you ask me what you like more, like a milled polymer like Pacton or SLM like the metal printing or milled titanium structure, I wouldn't be able to tell you what's more successful or what's better. I think it's a purely preference of the client and patient to give different solution options basically. So I would not know what I would basically put on the top tier here, right? They all work. They're all longevity is all great on these restorations, so it's hard to tell which is better.
So here we have the secondary frame that also shows the plungers on each side,
Right, and here's, I think it's not processed yet, right?
No, that's not, it's not processed
just
yet.
to fit over.
And then here we have a final restoration. So let's talk about the advantages. So the first one I would say is it's because it's very hygienic. So the patient can take it out and clean it. And like Alex mentioned earlier, we would like to see the patient wearing it 24/7. And they can, because it's easy for them to take it in and out. It's relatively fast for us to fabricate the restoration. So
yeah, because we can minimize steps, especially when we now incorporating digital dentistry. We'll show you later on a manual step-by-step clinical procedure, which looks pretty intense just because you have checklists and everything in there. But if we incorporate a digital process, what we discussed in the last modules, it's really, we can combine many appointments and we can do that restoration in 3 to maximum 4 appointments, actually. Really nice.
Yeah, that's awesome. It's very accurate. So by that, what we mean is that the titanium bar is melt, and then the overstructure, the secondary structure is either melt or printed. So everything is very, very accurate.
Yeah, it's almost like a glove. It slides over.
It's like a
really
glove.
Amazing, yeah.
On the economic side, it's not the cheapest restoration, but it has very long-term longevity. So for that reason, it's more economic, I would say, right?
It's right, yes. It's more economic in terms of the maintenance over time. Yeah, there's nothing would be has to get changed out in the attachments like nylon caps or so on. It's pretty much maintenance free instead of cleaning it, except after 4 or 5 years, like on any other implant reconstructions, we have to change the teeth because the teeth are acrylic teeth, like it's an overdenture. So the teeth has to get changed. They're made to wear, so the teeth will wear over time. So they have to get changed, let's say after 4 or 5 years, the latest, right? But that's like not a big deal in compared to many others, like a locator restoration where you have to change the nylon inserts sometimes 6 months in some patients, sometimes every year. It's quite different. So it's pretty intense in terms of maintenance. Here it's actually not.
And as far as aesthetic goes, so it's very highly aesthetic because it gives the patient nice lip support and it hides the transition line really well.
Yeah, that's really nice. That's where I see the biggest advantage here. Actually, we can really give the patient like that fixed restoration because of the locking mechanism, but we even can have a flange because the patient can take it out for cleaning and we can hide whatever is underneath basically.
And it's very long-term predictable. Yeah. So it lasts a very long time. In some cases, I think we can also do a secondary structure for the patient.
Second case, yeah.
Second case, yeah. In case.
Yeah, so sometimes we do actually a spare overdenture, the same, copy it basically for the patient. If something would break or chip or so, they just take it out and put the second one in, and then never without a restoration. This is amazing, right? In terms of long-term predictability, we have restorations out there with the MK1 for decades now. They're 10, 20 years in the patient's mouth. They all would change our teeth over time. And so the attachment itself can really last a very, very, very long time, which is really amazing. So now if we're starting towards kind of planning a case and going towards a case, that's like a little decision tree we made here. And I want to say thank you to Dr. Fava, Dr. Levine, and also Dr. Markrauer. They put that decision tree together actually. And I showed that on a lecture with it together. So I don't want to go too deep into that because there's a lot of decisions to make right in the tree. But there are basically 2 main routes we want to go with the case. This case on the specific patient we're going to show in a little bit. This patient has remaining teeth, right? So it's currently dentate. But if we have a currently edentulous patient, right, and we're thinking, well, we have a well-constructed denture, we can actually utilize that denture for converting existing denture to a digital hybrid on day of surgery or for the day after. Right, I think he even had a lower denture made, basically, this patient. I think he was in the mandible and dentulous, right? And if we have still teeth, so currently dentate, we can actually utilize these teeth as landmarks, can create a provisional with these landmarks, copying, maybe making it nicer, in nicer shapes and so on, but we can copy the size, we can copy what we already have and create a perfect provisional, what we can also convert on day of surgery or delayed to a transitional hybrid basically. So the patient has a screw-in hybrid for the healing phase of the implants. Why is this so good? Because it is just, the implants will heal faster. We can shorten that whole time until we can start with the final reconstruction, and patients just like it, right? They like it more than having a denture. I'm not a big fan of just a denture over healing abutments. Why? Because when the denture starts pushing disbalanced on healing caps, on healing abutments, on fresh placed implants, we can actually lose implants. So I'm a big fan of immediate loadings, either delayed or day of surgery. That's really a preference, but I'm a fan of, because we have it connected, the implant, it's strong, it's stable, and the literature actually proves, and will prove it again and over, it's a better solution for implant healing. So if we now look into the ideal space requirements, also I want to say thank you, Dr. Harris, Dr. Levine here for that slide. I put our photos here for restorations here, but the space requirement pictures on the models here are from the doctors above here. So the ideal space requirements here, if you go from left to right, for a fixed case like fixed frontal bridge FDP or an FP1, for example, we need between 7 and 9 millimeters minimum from the ridge to the occlusion or incisal edge, not from the implant. It's the ridge where we're looking at, right? On a hybrid, we're looking into 10 to 14 millimeter. I always say it's depending on the material we're working with. And then when we look into overdenture bar retained, like a Hato bar, what we discussed, I think in module 4, right?
Yes.
We discussed Hato bars. We need 12 to 16 millimeters because we have more hardware in there, right? We have a bar, we have clips, we have maybe a secondary construction. This all has to be hidden in that acrylic overdenture. So we need a little bit more space. For an overdenture just to implants, like a ordinary locator overdenture, right, which is the basic restorations for implants, we need between 8 and 10 millimeters for that restoration from the ridge, right? So when you look at abutments sticking out, popping out of the ridge, basically from that platform, we need these 8 to 10 millimeters for a metal reinforcement, for the copings or caps on top of the locators, and then for teeth and acrylic. So these are usually that space requirements. I always stress on that, and I always say, don't go religiously by these numbers. These numbers are average values. That's very important, because patients are different size. They're different size of teeth, different size of arches, right? So we have to be true to that. So a little small arch maybe doesn't need 16 millimeters for overdenture bar retained, right? But a really big arch maybe needs more than 10 millimeters for a hybrid. So keep it real, right? So we have to be true to that. There are different sizes, so these are average values, just to make clear that that's the truth. So if we now look into our clinical presentation, that's our first case, or actually that's the main case we want to walk you through, right? That's the patient you see is currently dentate in the maxilla and dentulous in the mandible. So here teeth are getting extracted and implants are getting placed, and we're basically converting a denture pre-made and immediate denture to a immediate loaded hybrid for the maxilla, and for the lower we have just a denture. So that was day of surgery or delayed, either or, it doesn't matter, right? So that it's the same result. So of the healing phase, the patient will have a fixed hybrid basically. Here we see a little strengthener, reinforcement, and we see 5 implants. So now after 3 months of healing, we're gonna take the final impression, or actually not we, because we're just technicians. You take the final impression. So important is photos are taken. Always take pictures. I always tell all my clients, photos, we all have to be good photographers, right? A dentist and a technician. We're really have to like to take photos of our patients, because that's like the most important communicating medium besides good records, good models or scans, because that will tell me what's going on actually in this patient's face. So photos are taken. A quick hint, 2 photos are main important is always full face, smile, and 1 retracted. The retracted photo, don't zoom in, just give a full face photo, right? I think we showed this a couple modules prior to that as well. There's a little template out there. If you're interested in a template and a photo template, just message us on YouTube or write us an email. It's info@zahnlab.com, and we're happy to send you the template. A counter model is verified and new one is taken if needed. So important is the models are clean without any distortions to be able to really make a nice restoration. The immediate hybrid, remember we had an immediate loaded hybrid, is removed, and then we're basically putting impression scoping on and verify that all seated perfectly, ideally maybe with an x-ray, and take an impression, an open tray impression That's your choice, right? So I always prefer open tray because it's more accurate. We also can connect the impression copings with a little floss and pattern resin. It's just more stable, basically. As an alternative, we can also make a verification jig from the immediate model from day of surgery and can utilize that to actually segmenting it, reconnecting it, and take the impression on that impression day 3 months after as a master cast impression, on a master impression. Remember, we're going analog to that process. Remember too, I said we don't have to do analog process. All these steps can be digital, so you can just take a scan, right? An intraoral scan with scan bodies, that's totally sufficient. And we explained in previous modules how we do that for implant restorations. So go back in module 3 or 4, I think, and I think module 3, we're going over digital dentures and how to take scans basically with that. So please go back, check it out, and be prepared. We're doing more on the digital side actually than now analog impressions. Then we have to make a verification jig, right? We're gonna seed the verification jig pieces that Dr. Makar prefers to have the verification jig segmented, connect them in the mouth, and then basically lute the jig together with a pattern resin or Duralay, and then use the jig for the final impression, right? So that's his preference. I say always use the verification jig, prove the passivity. If it's all passive and good, we actually have a good model, right? We don't have to necessarily segment the jig. That's a preference again, right? Impression copings are used for the jig, and you see here, that's a file that's ready for the final impression. Everything is healed. It looks fantastic when you look at the soft tissue here, right? And here you see the verification jigs here are segmented, reconnected, and ready for a final impression. We can also utilize a stone verification jig. We never talked about this over the last modules, I know, because usually we use stone verification jigs more for zirconia hybrids for fixed cases, but it's a great verification jig. Why it is so great? Because if it's not passive, it's going to break. And you have to reconnect the pieces like you see here, and then actually take an impression with the stone jig in place, or use that jig to make a base with analogs for a master base, basically. Right? So that's another alternative to do. If you have any questions to that, please contact us. I'm very happy to help you and walk you through that. And then again, we talked in the last modules about the mirror tray. You actually talked about this in your last modules. We talked about implant impressors for full arch. The mirror tray is an amazing impression tray which has a foil on top, and for open tray impression, the screw just popping through the foil, and you don't have to really drill holes in the tray and so on. It's really amazing.
It's a great alternative to a custom
awesome.
tray.
Yeah. But we see here, right? On the left side, we see the mirror tray. On the right side, we see the custom tray. Both works, right? But the mirror tray is it's quicker. It's really a good solution to use, right? And then we have to do the bite registration. Again, that's module 1, right? When we talked about bite registration, how important. By the way, these both bite registrations are both screw retained, right? We need stability. As alternative, we mentioned in the previous modules, we also can utilize locator abutment and locator caps to clip them on and off, which is really neat, right? But you have to have the locator abutments handy on the side, or usually we have to have them and send them to you to utilize that. So it's another good trick actually to really good bite registrations. Never forget to take the vertical dimension. This is taken with the provisional in place, because that's the vertical dimension we're targeting it, right? So we're going to take that, take a photo, and keep that stick. And then with the bite registration, we then can reconfirm that vertical dimension that we can give us, that you can give us, basically the laboratory, the correct vertical dimension. It's very important. Ideally, and I like this the most, we have master casts already, and we can actually cross mount the immediate loaded provisionals. If you have an articulator handy, you can do that as well. You don't have to have taken a bite, right? So that's like the perfect bite here, because these provisionals are in the patient's mouth since 3 months. They are really adjusted by themselves already, or by yourself, and they're perfect, right? As long as the patient feels comfortable. And then usually what we do here, we digitize the records. Just even if you go analog, we often digitize all the records to have it saved, because at some point in the lab, we are going digital with the restoration. You don't even realize that, basically, but we have many workflows now. We don't do analog anymore. We're actually utilizing printers and milling machines and design softwares to achieve certain results we want to do, right? So here we have then the case digitized. Jaw relation record, have the patient sit up, very important, straight up, right? Evaluate centric relation and vertical dimension of occlusion, and then basically talk to the patient. He has to give the S, the F sound. There should be 2 to 4 millimeter speaking space within the rims. All these things, you know that most likely, or you saw it in previous module, right? 60, 66, Mississippi. So we talk about, let the patient talk to you, right? Basically, that you realize, is it the correct vertical dimension? That's so important, right? That everything is nicely set and perfectly set up. Record the bite registration with the wax or bite registration material, what we saw before. We have the bite rims, we're squeezing out the material, the bite registration material in between, and can send that back to the lab that we can articulate the case. So then, we setting up teeth in the lab, or we printing a prototype when we go digital, but here in this case we're doing a tooth setup basically. So you get the tooth set up, the wax trine, remove the immediate hybrid, insert the wax trine and screw it in basically. It's a screw it in wax trine, and then evaluate the VDO and centric relation. At that point, if there's a complete misbalance between both arches, you can take out teeth, right? Especially we want to, or ideally, we keep the anterior teeth in maybe until the premolars to evaluate aesthetics and tooth position and also phonetics and take photos, right? Again, photos, I would always take photos in every step, not 20 photos, 2. Full face smile, full face retracted. It's all what we need, basically. Dr. Microw also likes a repose in profile, but we here in the lab literally needing 2 photos, full face, smile, full face retracted. And I would take these 2 photos on every appointment. They're quickly done. You can use even a smartphone. You don't have to have a big camera, because these photos are just literally for documentation where we are with the case and where we want to go, right? If another setup is required, we're doing a new bite registration with the setup and reset the teeth. If not, we can actually go then straight to, that's the wax trine, by the way, you see the screw access holes for screw retained. We can actually go to fabricate a bar. Important is the bar has to be fabricated not before the teeth are tried in. Why?
Because we need to know where in space we can go with the bar, according to where the position of the teeth is.
Exactly, because the bar is made to the teeth, not the teeth to the bar, right? So that's very important. If we're creating a bar, guessing where the bar should be or the teeth should be, and the bar is in the wrong position, the whole case is a failure. So we have to first do a tooth try-in. That's a very important point. That's most likely the most important point of this hour today. We have to make a tooth try-in first before we creating a hardware, the bar basically, right? It's very important because that's the main question of getting asked, or when we're getting a case sent, please make an MK1 bar. And no, we have to verify first, and we have to make a tooth setup to basically make sure we have the teeth in the right position, the vertical in the right position, that we can create the perfect bar, right? And then we have the bar milled, and in this case, we're actually milling a secondary frame out of Pecton. It's a high-performance polymer. Again, I'm not able to tell you what's better or worse. All these materials working very well. We have very good success with all different materials. What we're utilizing our secondary frames is more like a preference. Yes, there are borderline cases where it's very, very thin, where its vertical dimensions may be challenged. I would rather go with metal at that point. But in general, we can utilize high performance polymers, speak Pecton, SLM, speak chrome cobalt, metal printed basically, or a titanium milled bar. They all work, right? So they're all pretty good. The fitting is amazing. They're like a sleeve. They're really, nowadays the technology we have, it's just absolutely amazing. And here we see that Pecton bar with the attachments integrated. We see the little plunger sticking out to the lingual. These are the plungers that go in and out basically. And we'll show you later, or you can show this actually, how it actually works on the case, why we have that. So now, wax trine number 2. Why 2 wax trines? Well, I rather do another trine before I have to grind acrylic and make a whole new setup, right? So usually we like to actually try in our transferred wax trine from wax trine number 1 to the bar, to the hardware now, that everything fits and everything is transferred perfectly as before. Yes, we can prove it with matrices and so on, but believe it or not, we do have the fact that we're coming back after the second try and, hey, can you change this a little bit here? Now we realize we want to have it different. And then, yes, we can do and can go to a finish. So that's very important. So wax trine here, we see different snippets and pictures out of the trying here. Now intraorally the bar is screwed in, Waxtron is tried in, and here we have the teeth in place, and then we have the case finished, processed, so we have to remove the immediate hybrid, seat the milled titanium bar. We tighten now all screws by hand, alternating from side to another, so we're going crosswise like we would change a tire in the car, right? Wait 5 minutes, and then we torque to 50 newtons if you go to implant. If you go to multi-units, it's 15. Keep that in mind, right? Different implant or different abutments, different screws need different newtons, different torque values. Our webpage, zahnlab.com, will show you the different torque values of most implant platforms. So you can go on there and have it literally like saved on your screen. It will show all the torque values, right, all the time. Place the MK1 case, evaluate occlusion, make sure everything is nice, adjusted and in excursions, and then instruct the patient how to insert and remove. That's very important. The patient has to be comfortable in inserting and removing that restoration. And then some instructions for oral hygiene, and we schedule a next appointment, right? That's the insert, that's the processed case here. Here is the intraoral view, and we have the case seated. Usually the seating appointments are quick in the mouth here, and we see these little holes on the side. You see that I told you guys we're going to explain how the case goes in and out, and these holes have a certain functionality for a little tool we need for that specific attachment. So after 1 week is a follow-up, basically. Patient should sleep with the prosthesis in place, not just for 1 week. The patient actually should sleep with that prosthesis all the time. Night guard, usually I always recommend for all restorations wearing a night guard. It's like you're getting a new car. It's the same price, by the way. The new car has to go in the garage, right? Ideally a new car, so you do the same thing. The night guard is the garage here. Review, check occlusion, review patient's hygiene, reinforce the maintenance schedule, which is very important, right? Patient has to know what they have to do. And then every 3 months, a hygiene appointment like you usually do. That gives you the chance to get the patient back, check the restoration, call the lab if maybe something has to get repaired, and we're good to go. And here's the final case, very happy patient. And these, like I say, these restorations last normally really a long time. Patients are very happy.
So these coming up slides are my favorite slides. So you can see here the measurement for the space which we need for an acrylic hybrid, which would be 14 millimeters and only 10 millimeters for zirconia.
So why is that actually?
Because the acrylic is a different material from the metal, and there's a lot of components that have to bond together, and because of the strength, where the zirconia is just one material.
It's got monolithic material basically, right? Okay, cool.
So limited space situation, this is why I like the MK1 bar, because you can utilize it in even like irregular ridge areas. So here you can see that in the anterior region we don't have much space. We do need 6 to 8 millimeters from the implant platform to the incisal edge. And then on this slide you can see that we can actually fabricate the MK1 bar in 2 parts in the posterior region. You don't have to go all the way across.
Especially for these uneven ridges, right? So you don't have the 6 millimeters, or even if you have 6 millimeters, we still can just keep it out, have more space basically to not even go with the bar there. Yeah,
exactly.
That's really cool.
And here we have the secondary structure with the plunger attachments in place. However, they're not attached yet. And then here you can see them being attached in the secondary structure with acrylic. And it fits like a glove basically.
Yeah, I like the solutions a lot with 2 bars. The only thing I have to say, we did this quite often in the past, 2 bars, but it's a little bit more user sensitive, not from a patient user, from a production workflow, right? So because you have the 2 bars now, so we have to make sure the model is really, really, really accurate, because if there is a slight disbalance on both bars, the restoration will not fit. So really have to make a verification jig connected to everything, right? And both bars have to be verified that everything is really perfect. I like sometimes to actually even do a pickup of both bars in the mouth with a custom tray to have a new master cast with the picked up bars before I do a secondary frame. That definitely helps for accuracy. But besides that, it's an amazing solution for these extreme cases where we don't have really a lot of vertical in the anterior area.
And then here you can see nice examples of the solution from basically milling of the substructure part, and then digital design of the overstructure. And again, that was the...
Yeah, then that's basic. Then after digital design, we can then metal print that overstructure. And it's very technical right now. And but it's cool. It's a cool process. I really like it. You see here that SLM, selective laser melting kind of procedure. You see there's that slide, or that applies the metal powder, cobalt powder, and then the sparks flying. Basically, that's the laser which melts these powders in place, and that goes layer by layer by layer, right? It will take a couple hours or a few hours actually to really build that frame or crown and bridge work basically. But you see here now we're seeing these structures coming out of the powder, right? And then after the whole plate is melted, the slat goes to the other side, applies another layer of powder, and then the next layer basically gets melted together to a final shape, which basically looks like this here. What we see on this photo here. These are crown bridges, but even the secondary frame looks the same, right? It grows up with that metal plate, and it's a very clean process. It's a very nice fitting process. So we're utilizing this a lot lately for all metal reconstructions, either milling or we do selective laser melting.
And again, here you can see the final product and how everything fits very precisely like a glove.
Yeah, that's the key.
Okay, and this is what Alex was mentioning earlier. Here here you can see the tool that is used to push the plungers out so the patient can take the prosthesis in and out of their mouth.
So that's I think we have to explain a little bit more, because this is that tool. It's a very a little tool, fits in any pocket basically, in a bunny pocket even, and you push. And the plunger comes out, you can take it out, you put it back in, and all you have to do, put the plunger with your finger lingually back into the hole, which is really easy. If you have a patient with dexterity problems, right, or Parkinson patients, for example, they cannot do that. We have to be true to that, right? So that restoration is amazing for most patients, literally. There are exceptions for patients. They may be, or your patients, they maybe cannot deal with that little tool, which is very thin. It's almost like a paper clip, but finding that hole, right? It's not as easy for these patients. It's easy, but for some patients, it's going to be a little bit challenging sometimes to find that hole. So then we're back with telescopes. Right, yes. So that's the great thing. So we have these two solutions. Remember at the beginning of the webinar today, I mentioned I don't like just one solution. I like two solutions, or three or four. Right, so we have at least two solutions for these different scenarios, which actually most of the time go both hand in hand. Right, they work for most cases. Both are removable. Both are feeling like a fixed case. One case is really locked in, but we need a tool. The other case, the telescopes are easy to deal with, more petite basically. So that's the advantage there. So if you have a patient with dexterity problems, the telescopes are maybe better. If for all other patients, the MK1 is like super rock solid basically.
Yeah, so here you can see all the parts. So here we have a hybrid, actually, zirconia hybrid on the lower. And then that's an MK1 bar on the upper, and you can see all the hardware with it.
Right. Cool.
And here's our finished case.
Yeah, perfect. Happy patient. That's a cool video I'm going to show you now. Just watch and enjoy. I want to explain later.
There are only certain foods that I could eat, and there are foods that are basically soft foods, stewed and that kind of thing. In fact, I could barely eat a banana.
John Turner is a world-class barefoot water skier who had experienced severe tooth and gum problems. He wanted a secure way to replace his teeth, resume normal eating habits, and feel confident in public again. But John had another motive. He wanted to add a new stunt to his competition repertoire.
So he's a water skier, barefoot water skier, and his favorite stunt is to basically biting into the handle and let him pull just with his teeth. And believe it or not, this guy has an MK1 for the maxilla and mandible in his mouth, in acrylic, right? So it's insane. But it's an older video, and you can tell. So the MK1 attachment is nothing new. Again, it's like it's 30, 40 years old from Germany and still working very well. So this guy has that in his mouth and does that basically as a hobby or semi-pro, whatever he is, right? So that's really cool. So that's why I was excited to show the video, just because people don't even believe that can be done with the restoration like this, right? The full arch acrylic upper lower restoration. So let's see here. So as concluding for tonight, I would say I love the sentence actually, where challenges are, there are solutions. I always say there are always solutions, right? There's always a solution for a certain challenge or problem in our industry. It's all focusing on industry sometimes. Sometimes there are challenges we don't have a solution for. But in our industry, usually I wouldn't be able to tell you where I was not able to find a solution for a certain dental scenario, basically, on the restorative side. We have to understand, though, the patient expectations. And because if we understand patient expectations and listen to our patients, we can educate accordingly the right way. And that will sometimes, or most of the time, also help us not going into a disastrous situation. If we just follow the patient blindly, it's, oh yeah, oh, you want to fix, no problem, we're going to make a hybrid, without actually consulting with the lab or as a surgical clinician with your restorative dentist or with a prosthodontist, and don't give that patient other options, we may ending up in a dead end, right? So we really have to understand what these patients are coming from, why they're here, where they are right now, and where they want to go as a final. That's very important. Really, we have to understand that. Unfortunately, nowadays dentistry, especially corporate dentistry, doesn't allow this sometimes, right? Because we're so under fire, we're so quick with everything, and in some big clinics, patients are just numbers. So that's unfortunate. But I hope there are enough private dentists, they're really watching tonight or watching the recordings. You guys really have the time, you have to take the time to educate your patients accordingly to get the best out of the situation, to help these challenges, right? And that's always, I love zirconia. I love to do fixed restorations. I'm a ceramist actually by heart, right? But fixed is not always the way to go, the best way to go, right? It's not. There are sometimes solutions, or not solutions, there are sometimes challenges or situations we have to find a different solution, which sometimes is removable, right? So fixed is not always the ideal way or ideal solution for every case. It's just reality, right? And I think the MK1 solution is serving as a fixed solution. That means like the MK1 is so rock solid in the patient's mouth, it is like a fixed case. I have clients that utilize the MK1 almost like a hybrid without flange. There's bone removed. The design is like a hybrid design with a nice round integrity surface where the bar is and the restoration just slides over. The patient never removes it. They're cleaning it with water pick. The patient goes to the office every 3 months, their hygiene appointment. All what the hygienist has to do with the tool, click, click, taking it out, cleaning everything around the bar and inside the restoration, and sends the patient home. And that's pretty cool as well. Keep in mind, it's always a design thing, right? So how we design it, we can use and wear it basically. So I want to say thank you. Thank you for keeping up with us for 6 weeks. Actually, we had 8 weeks because we had a 2-week break. So keeping up with us for 6 modules. It was fun, Veronica, to do this with you. It was really cool. We're going to do more of these. Again, work out that Wednesday webinar or webinar Wednesdays. It's a really cool thing. We want to keep going with that. Most likely not every week. So we have to build some content. Actually, crossed my mind. I love to improvise, right? Danielle hates me for that, but I love that. Write us what you would like to hear next, right? Well, how about that? Give us topics. Give us topics you would like for us to discuss, to show, to share our knowledge. I hope we can really go into everything what you would like to know. And if not, then we find a solution. Maybe there's somebody else here on a Wednesday, on a webinar Wednesday to speak, right? That would be really awesome, actually. Please let us know what you would like to hear from us. I think that's really cool.